Welcome to the Checking In podcast from the Great Lakes MHTTC, a series discussing topics related to health equity and the destigmatization of substance use disorder and mental illness.
Welcome to Checking In podcast. I'm your host, Velez, and this episode is dedicated to raise awareness about PTSD in children and youth. I'm promoting self-care practices among clinicians who serve clients or patients who have experienced trauma. Today, we have the privilege of speaking with Dr. Michael Gomez, a clinical psychologist with expertise in trauma-informed care and working with children and youth. Welcome, Dr. Gomez.
Thank you. So I appreciate being on the program.
Let's dive right in. We are interested in learning about the work that you do and what inspired you to pursue this line of work.
So by trade, I'm a clinical psychologist, clinical child psychologist specifically. I do a lot of work with the National Child Traumatic Stress Network, NCTSN, done initiatives in training providers, providing direct therapy, research, policy work across the U.S., and also for about a month or two in Southern Africa, Swaziland, now called Eswatini with the World Health Organization. But primarily I identify as a therapist, as a clinician. And part of the reason I work with kids, I do have experience working with adults with trauma. I did a year in combat stress at the Veterans Administration with our OEF veterans and Vietnam veterans. But my first experience was I was in AmeriCorps, was a AmeriCorps worker. Some people listening to this know what that is. It's a wonderful program. And our grant funded the Community Mental Health Center in West Texas, where I grew up at. And so I was working in an inpatient unit with also my other site was with kids, and all the adults on the inpatient unit had trauma. Well, my kids had trauma, so my thought back then was, why not start before they hit their 30s and are hospitalized? So that's why I work with kids primarily, although again, I have experience with adults.
Wow, that's fascinating. And I had the opportunity to visit Swaziland too in 2012. It's so beautiful.
It's beautiful. Love it.
We are going to talk a little bit about what is PTSD. Can you share to our listeners what are some common signs and symptoms of PTSD in children?
Sure. PTSD, keep in mind, is one type of traumatic stress disorder kids have. There's also things called developmental trauma disorder, complex PTSD, which is PTSD's nasty, bigger, older brother. But to directly answer your question, it looks fairly similar in terms of concepts to kids, but the way they manifest may look different. So a good example is re-experiencing symptoms. Veterans I work with would have flashbacks about the war. Kids will have nightmares, and the nightmares may not be about the perpetrator. They might be about monsters. I have a lot of kids who dream about monsters. One of my 6-year-olds at intake told me, monsters visit me in my dreams every night, Dr. Gomez. The saddest thing ever heard. And big part of PTSD is it's one of the only diagnoses you have to not want to talk about. It's literally in the criteria, which makes it very confusing for people who have no idea about this diagnosis, is that you'll often see teachers, even like providers or the therapists, say, well, they didn't talk about it, so it must not bother them, when they're unaware that in the actual diagnostics, it's criterion C out of the criterions for PTSD, A, B, C, D, E, F. Criterion C is you got to not want to talk about it, it's avoidance. And the easiest way to answer that question is one of my colleagues, the National Network, Dr. Cassie Cassell, says PTSD is the great imitator. It looks like everything but PTSD. So it looks like anxiety, depression, it looks like headaches, it looks like backaches. It looks like learning disabilities. It looks like autism. It looks like relationship problems. There's very good screening tools for this. They're very well respected and validated. So it's easy to do a screen, even by a pediatrician, but it's an imitator, is probably the best way to describe it.
Thank you very much for sharing that, because sometimes kids are diagnosed with anxiety or depression, when actually they're kind of like inside the umbrella of PTSD. So I think that was really helpful to share. What are some effective treatments or EVPs that you use to treat children and youth with PTSD or developmental trauma?
Yeah. There's a number of treatments. You can look them up at the California Evidence-Based Clearinghouse. It's a wonderful resource. Also, SAMHSA has a registry for evidence-based practices. One of the primary ones I use is trauma-focused CBT, TF-CBT. I'm actually one of the 70 national trainers in that. And we like to call TF-CBT the amoxicillin for traumatic stress in kids 3 to 18. That's kind of our front line. It's not the only medication, the only antibiotic. But it's a pretty effective and common one, and it can work for all different types of traumatic stress, not just PTSD, but complex trauma, developmental trauma. We have data that works now with kids with autism who have been abused, and many other different populations. It's been done on every continent on this planet except Antarctica, and in our defense, the penguins were very unhappy with that. And other types of therapeutic models are parent-child interaction therapy, child-parent psychotherapy, and you'll see other ones that kind of straddle what we call transition age, such as like 16 to 24, such as Target, Seeking Safety, things like that. The probably easiest way to answer the question is every one of my trainings has to read the book Trauma and Recovery by Dr. Judith Herman, which contains where a lot of our models are theoretically based in. And she actually developed the book not by talking to other psychologists, by talking to survivors. So it's and as a person who has lived experience, who is very upfront about their history of childhood trauma, I found that very refreshing, that it wasn't just, person in an ivory tower talking about trauma, but someone who went on the ground, talked to people, war veterans, domestic violence survivors, children, and they put together a way on how we recover.
Thank you very much for sharing. TF-CBT also has a lot of, it works with Latinos too, and there's some modification for the Latino population too, right?
Yes, we have, I believe, 7 fully bilingual trainers who have translated and back translated pretty much every material, all the materials we use for TF-CBT, and it's been used across Central and Latin America and Spain, pretty much anywhere people, identify as Latinx, we've used it there.
Great. How can youth who experience trauma build resilience and cope with PTSD symptoms?
Yeah. Fairly complicated question, but it's actually a pretty simple answer is caregivers. That's a very simple answer. A little bit more elaborated answer is one of the things, especially in a model like TF-CBT, that we find is that it's caregiver driven. A good way to think of it is the family system is your psychological immune system, which explains some really interesting data that we see, such as kids who have parents who are manufacturing or using drugs. Those kids have worse PTSD symptoms than kids who are on the Gaza Strip or in Bosnia. And it's not because those places are, very nice places or very pleasant places. It's that because usually their family system is intact. There was a study that Dr. Esther Demlinger, one of our developers in TF-CBT, did where she looked at 3 groups, all got better because all got TF-CBT, but the groups were parent and children get TF-CBT, parent only gets TF-CBT to use for their kid, and the child only gets it, like child-only therapy. Gold medal is obviously the parent and the kid, but the silver medal was the parent-only condition. The kid never walked in the clinic in 20 weeks, and they had more symptom improvement and more resiliency than when they saw the kid alone once a week.
Wow, that's really good data about how important it is to have a community, right?
Yeah.
In your experience, how does working with trauma can affect the well-being of clinicians? And if there are some self-care practices that you do, could you share that too?
Absolutely. The misconception is that you have a choice if you get burnout or secondary trauma, also called vicarious trauma or compassion fatigue. You're going to get it. It's just what you do with it. We're one of the only fields that gives people a hard time for this. I have an uncle who is a plumber and comes home smelling like literal feces because he's a plumber. And my family's reaction is that's man's work. He's a good man. He worked very hard. They're very proud of him when I'm telling him to take a shower. And we're the only field that does the opposite. No one says, Dr. Smith, that's a psychologist right there. They were crying in their car about that 10-year-old they work with. It's an amazing provider. No one says that. And so we've come from the starting point that you will get this. It's just what you do with it. And we tend to make a differentiation at the national network between capital S self-care and lowercase s self-care. Capital S self-care, a good resource would be PRN, Pause, Reset, Nourish. It was developed by the Secondary Traumatic Stress Work Group at the NCTSN. Very quick, very in the pocket, less than 60 seconds. Things you can do right now. Lowercase s is what most people understand when we say self-care, like take a bubble bath, go for a run, have some coffee. We are pro bubble bath at the national network. At the same time, we don't think that's going to address the 3 suicidal kids that you have this week. And so we're much more a fan of integrating practices on how to not just reduce your secondary traumatic stress, but also enhance your engagement. Because your best days are often your most stressful days. But it's not your stress that's really hurting you. It's your stress plus your hopelessness, stress plus your despair, stress plus your helplessness. You have to have another ingredient for your stress to actually activate before it really gets you. The model I practice was developed by Dr. Brian Miller out at, he was a former chair for the Secondary Traumatic Stress Committee at the National Network. It's called CSIRT. If you type in Brian Miller, Brian with an I, in Amazon, you'll get his manual, Reducing Secondary Traumatic Stress. It's the CSIRT model. One of the particular problems we have with lowercase s self-care is that it puts the responsibility on the provider and only the provider. So if you don't do your self-care, you're kind of a bad provider, right? You should do your self-care. Whereas in the CSIRT model, we believe that secondary trauma and burnout are an individual impact, but an institutional responsibility. I said this once in a meeting with leadership at the hospital I currently am at, and it got everybody a little ruffled. And my fairly admittedly snarky reply was that is the exact policy this hospital has on COVID-19. It is an individual impact, but an institutional responsibility. You don't see nurses on unit just like, hey, you got to buy your own N95. You got to figure out how to deal with COVID. They allot time within their job, not hours, but a good, some minutes, like half an hour, like you got to put on your N95 and your respirator, and we got to give you time to learn how to do this and to do it effectively and safely. And we think that such integration is exactly what is needed for institutions, and also to not make it feel like the provider's a failure, because they aren't. They're working very hard. I'm thinking especially of our teachers who work a lot with our kids. Self-care is their responsibility, but our belief in the CSIRT Trainers Network is it's the institution's responsibility, although it is impacting you definitely.
I think it's really important also to create that awareness that is not just on an individual level. The clinician needs to take care of themselves, but also in an organizational level too.
Yes.
And one term is about what is psychological safety inside the workplace, and how we need to continue to increase psychological safety. Is like creating spaces where clinicians can feel that they can share of their struggles, right?
Yes, definitely.
Is there like a particular self-care that you want to share that you practice?
Yeah, I do. I referenced it a second ago, the CSIRT model, CE-CERT. It was developed by Dr. Brian Miller. Again, the manual, it's a workbook. People can get it on Amazon. I originally was using Laura Vandernoot-Lipsky's book called Trauma Stewardship. Wonderful book, really love it. But we have 5 components in the CSIRT model: engagement, reduce your rumination, create your own narrative. We all have a narrative. We just often aren't aware of it. Parasympathetic recovery. These are kind of our closer in the pocket skills, like doing your mindfulness activities, your breathing. If you do yoga, we can integrate it in there easily. And we replace the term compassion fatigue with emotional labor. We don't think that compassion fatigues you. We think it actually charges you up. When you feel truly compassionate, you feel very energized. A good example is people who have faith-based practices. I was raised Catholic, and so my tias do rosaries a lot. And to me, that looks very exhausting, I'll be honest. Seems like it takes hours. I know it doesn't, but it's my perception of it. But at the end of that rosary, they are very charged. They are renewed. And that's essentially what we're getting at. You can do that entirely secularly. It doesn't have to be through a faith practice, but that's a good example of what we mean by compassion charging you, not fatiguing you.
Yes, absolutely. Do you have any final thoughts or recommendations related to well-being and self-care for our listeners?
Yeah, if I could plot 1 or 2 things in your listener's head, it would be the following. First one is during the pandemic, and I know COVID has changed the lay of the landscape, everything's gotten worse. Our numbers are worse than they've ever been. Our systems are more broken. And so we feel that we've lost and we've been defeated. And I got into this job in large part because I wasn't that great of a kid. I was a pretty violent adolescent, did time in juvenile detention, and I made the world a worse place for a while. And so I felt fairly obligated to make it right. I also, again, was raised Catholic, so I feel guilt for things I cannot possibly be responsible. But during COVID, I used a lot, especially the CSER components, to engage in that conversation, that self-dialogue, and realize the thing that I would like, first thing I like to plop in your listeners' heads, which is whatever I owed, I paid it and then some. So I'm done with obligation and starting with opportunity. So no more obligation, only opportunity. And if you could get that mantra in your head, especially providers, and even especially students, by the way, you were a student during an apocalypse, during the worst health crisis we have ever seen in a century, and you are still there. Which is, it goes to the second thing, which is the thing I really struggle with, and it's probably the hardest skill for me to learn, is self-compassion. Very good about being compassionate to others, but to go easy on myself, to be kind to myself, and even just being semi-forgiving, I still struggle with that, and maybe always will, and I'm okay with that. But I tell my trainees, the struggling is succeeding, trying is succeeding. And so as long as you're still here, as long as you have breath, and as long as you're trying, you're succeeding.
Thank you very much for sharing your knowledge with us and sharing your self-care practices. Thank you very much, Dr. Michael.
Well, Isa, thank you for inviting me. I appreciate it.
The Checking In podcast is produced by the Great Lakes Mental Health Technology Transfer Center with funding from cooperative agreements with SAMHSA. We encourage you to connect with the Great Lakes ATTC, MHTTC, and PTTC on Facebook, LinkedIn, and YouTube to discover many more free products and resources just like this.